of respiratory medicine, including tough ones also as well. So Madhukar is a versatile speaker. I am seeing him again and again. It means that you are much interested in difficult teaching as well. So I will start the session.
So, sir, today we are fortunate to have Dr. S.K. Madhukar, a renowned pulmonologist and master teacher class, and he is going to deliver talk on lung protective ventilation. This topic is very crucial in the management of critically ill patients, particularly in those with acute respiratory distress syndrome. Dr. Madhukar expertise in respiratory medicine will guide us through the principles and practice of lung protective ventilation, including strategy to minimize ventilation-induced lung injury and optimizing patient income. Please join us, and I would request Dr. Sanjay Kumar in welcoming Dr. S.K. Madhukar to the stage, and I am confident that his presentation will provide beautiful insight, valuable insights, and practical guidance on implementing lung protection ventilation in clinical practice. Over to Dr. S.K. Madhukar.
Thank you so much, sir. It's my absolute pleasure, privilege, and honor to be here on the platform of ICP. And
a bit louder, sir.
Sorry, sir.
A bit louder.
Okay. Thank you so much, sir. It's my absolute pleasure, privilege, and honor to be here on the platform of ICP, which has been driving an excellent academic extravaganza, and respected dignitaries, Dr. Kamlesh Tiwari, sir, who has been my teacher, my inspiration. Dr. D.P. Singh, sir, you have always been like an elder brother to me, guiding me through my career. Dr. Sanjay, sir, he has been the one who beckon these academic activities in Bihar. So thank you so much for giving this platform. Today, over the next 1 hour, I would be talking about lung protective ventilation. Lung protective ventilation is a strategy to protect the lung, at the same time ventilate the patient. It has become quite popular amongst all the pulmonologists, critical care physicians, and all the physicians alike who see the patients with the respiratory failure. Though it has been widely used in the patients with ARDS, now this lung protective ventilation strategy has been extended to other patients who are critically ill, including the patients who are in sepsis, having sepsis with multi-organ failure, the patients with any kind of diffuse lung disease, for example, the patients with interstitial lung disease with respiratory failure, the patients who are being ventilated with the normal lung, for example, during intraoperative procedures. So any patient with diffuse lung disease, whether it is ARDS, whether it is interstitial lung disease, any patients with sepsis in which we use, we try to protect our lungs. So this strategy has become quite popular, and we all need to understand this strategy of lung protection. Just moving the slide. Few glitch with the moving of the slide. I'll just check it and I pardon for a few minutes as I'm finding some technical glitches. To move the slide, I'll just seek the help and just give me a minute to move ahead. slide movement. Okay. Yeah. So when we talk about respiratory failure, we talk about failure of the respiratory system. Let's understand what are the components of the respiratory system. The components of respiratory system are controller, respiratory pump, and gas exchanger. These are the three components of the respiratory system. Controller sets the respiratory rate. Pump means pushing the air into the lung. Gas exchange means facilitating oxygen delivery to the blood and extracting CO2 from the blood. So we have the three components of the respiratory system. And failure in any of these component of respiratory system leads to the respiratory failure. So when we use mechanical ventilation, we need to address or we need to take care of all these three components of the respiratory system. In mechanical ventilator, setting the respiratory rate is not at all a big problem because of the engineering techniques that the ventilator have, and we set the respiratory rate. In mechanical ventilation, at least for the oxygenation, we have supplemental oxygen to give to the patient. So what basically is the essence of understanding mechanical ventilation is the understanding of the ventilator pump, respiratory pump. And this is where the entire knowledge of mechanical ventilation is needed. And to understand the mechanical ventilation, mechanical ventilator per se, we need to understand the ventilator pump. For this, I'll have a very simple example. Let's assume there is a tube. And through this tube, we want to pass a gas, any air. Now, at the one end of the tube, we suppose there is a pressure, we call it P1. And at the other end of the tube, so there is a pressure, we call it P2. Now, this is a simple understanding or illustration of the ventilator pump. For any flow to occur through the tube, we will have to create a pressure gradient or pressure difference. If we create a pressure difference, then the gas will flow or the air will flow. The entire ventilator pump is based on simple principles of Ohm's law. And it says that for an air to flow through, we need two things, that a pressure gradient has to be created, and this air should resist or should overcome the resistance of the tube. So by Ohm's law, the pressure gradient is equal to flow into resistance. Now, what this pressure gradient is? Pressure gradient is the difference between P1 and P2. Now, we suppose that P1 is the pressure at mouth and P2 is the pressure in the alveolus. So, if we create a pressure gradient between mouth and alveolus, then the air will start flowing or the air will start moving into the lung. We had the negative pressure ventilation. In negative pressure ventilation, we decreased the P2. Alveolar pressure was decreased. And so the air started flowing. Nowadays, we use positive pressure ventilation. In positive pressure ventilation, we increase the P1, that the mouth pressure. And so the pressure gradient is created and the air starts to move in. Now put this illustration into the human lung. What happens? There is an airway, and at the end of the airway, there is a balloon we illustrate this balloon as an illustration of the alveolus. So airway is attached to alveoli. Now for air to flow through the airway, it needs to overcome the airway resistance. Now air to move in the alveoli, it has to overcome a opposing force. We call it elastic recoil. Elastic recoil is an inward force. So if air has to move into the alveoli, this elastic force has to be opposed. We also call it stiffness of the lung. So that stiffness has to be opposed. And we also call it compliance. Compliance, it's in a mathematical terms, the compliance is the change in the volume of alveolus per unit change in the pressure. That the pressure required to change the volume. So we see that from P1, a higher pressure, to the P2, a lower pressure, the air starts to move in, and in the airway, the flow has to overcome the resistance. In the alveolus, flow has to overcome the elasticity, elastic force or stiffness. Now, if we plot this on the pressure time graph, that how does pressure change with time? Now you will see in the lower pressure time graph that is there, you will see that at the beginning of inspiration, the pressure rises sharply and it reaches to a peak. And at the end of inspiration, when there is no flow, the pressure becomes plateau. So pressure becomes plateau and air does not flow. And when the expiratory valve opens, the expiration begins and the pressure starts falling. Now in this graph, we have two pressure. One is the airway peak pressure and another one is the plateau pressure. So we can see here in the graph. Let's understand airway peak pressure. The peak airway pressure is the pressure to overcome both the airway resistance and the elastic force in the alveoli. So this is why a peak air pressure is generated. Now, plateau pressure. Plateau pressure is when there is no flow into the lung. So when there is no flow into the lung, what does this pressure does? When there is no flow into the lung, at the end of inspiration, the alveoli needs to be distended and the pressure required to distend this alveolus is against the stiffness or elastic recoil of the lung. So plateau pressure doesn't have to overcome the airway resistance because air is not flowing. The flow is not there. So if the flow is not there, there is no need to overcome the airway resistance. What is actually need to overcome is the only elastic force of the alveoli, an opposing force in the alveoli or a stiffness of the alveoli or compliance of the alveoli. So peak airway pressure is a pressure to overcome both the resistive as well as the elastic forces. Whereas plateau pressure is the pressure to overcome the elastic forces only. So if you if you subtract the plateau pressure from the peak airway pressure, it will give the idea of the resistance of the airway. And this is how it is very important for us, for all of us to understand this, that if you reduce the plateau pressure from the peak airway pressure, it will give the idea of the airway resistance. So if the peak airway pressure minus plateau air pressure, if you reduce the plateau airway pressure from the peak airway pressure, it will give an idea of resistive force, and it should usually be less than 10 centimeter of H2O. Now, understand this. If a patient has high peak airway pressure And the difference between peak airway pressure and the plateau pressure is more than 10 centimeter S2O, it indicates that the resistance of the system is high. For example, a patient with COPD or asthma. So in the ventilator, you have the peak airway pressure, you have the plateau pressure. If the peak airway pressure is high, if you are finding that the airway pressure is high, you reduce the plateau pressure from the peak airway pressure. And if it is more than 10, then it means that the airway pressure is because of high resistance of the airway, and you have to treat the patient to lower the airway resistance, for example, with the bronchodilators. But if the peak airway pressure and plateau pressure both are high, and the difference between these two is less than 10, that is normal, then it means the primary problem is the stiffness of the lung. Primary problem is the lower lung compliance. So it gives a complete understanding of the lung pathophysiology by looking at the peak and plateau airway pressure. So let's come to lung protective ventilation. With these basic understandings in mind, we will move to understand the lung protective ventilation. The ventilation strategy where your lung has to be protected against barotrauma, volutrauma, or atelectrauma. How are we going to do this? Lung protective ventilation have three strategies: restricting the tidal volume, restricting the plateau pressure that we just discussed below 30 centimeter of S2O, and providing a high PEEP. First, restricting the tidal volume. Restriction of the tidal volume has been understood as the most effective method to prevent the lung injury. Now, it has been suggested that the tidal volume that we need to give to the patient on mechanical ventilation is 4 to 8 ml per kg of ideal body weight. But the drawback with this rule of thumb is that every lung is not equal. And why are all lungs not equal? Let's understand this. So if you're giving 6 to 8 ml per kg of tidal volume to every patient, what's going to happen? And therefore, the concept of baby lung came. What is baby lung? Baby lung is the normal lung tissue amongst the diseased lung. So if a lung is diseased, the portion of the lung which is not affected by the disease is the baby lung. And we utilize this baby lung to our advantage because the baby lung is still functional. Baby lung is still recuratable. We can recurate the baby lung into the ventilation, and this baby lung has a normal compliance. So this portion of the lung which is not damaged it has to be utilized for our advantage, for the patient's advantage. Now, measurement of the baby lung, how would you know that how much baby lung is there? Bedside measurement of baby lung is not possible. So we are using a surrogate marker for the measurement of baby lung. And we all know this, that we predict the lung size by ideal body weight, not the actual body weight, depending upon the sex and the height. But the caveat is, this predicted lung size is not always equal, not always the same. Even with the same sex and the height, the two people might have different lung size because For example, if you see a patient with the baby lung, even a baby lung might have a portion of the lung which may not tolerate that much of the tidal volume. And alveolar overdistension is a possibility even in the baby lung. To understand this, for example, let's consider the left lung, which is encircled in the red. Now, this is the normal lung. A normal lung can tolerate a tidal volume even greater than 8 ml per kg of body weight without any harm. But abnormal lung, which is encircled with the blue, which is a diseased lung or abnormal lung, here a patient, there might be a portion of the alveolar collapse. And when there is alveolar collapse, a lung volume of 4 to 8 ml per kg of ideal body weight may not be sufficient to recruit it. They might need higher lung volume. And also, there might be a portion of the lung where in the baby lung, where even the 4 to 8 ml per kg ideal body weight of tidal volume may be excessive, and that may cause the alveolar overdistension. So, a tidal volume restriction alone doesn't seem to work well with in all the conditions, and it doesn't give us the surety of the lung protection. So is there any other method by which we can refine the tidal volume delivered to the patient so that any harm doesn't occur? Yes, there is a protection against this. We call it plateau pressure. So the second strategy of the lung protective ventilation is plateau pressure. We adjust the tidal volume and PEEP in a manner that the plateau pressure does not exceed 30 centimeter of H2O. And what the plateau pressure is, we all understood this. When there is no flow, the pressure in the alveolus when in the absence of flow. So that plateau pressure is an estimate of the compliance of the alveolus. How is it working? You have seen the pressure time graph during the initial introduction. So initially, with the beginning of inspiration, the pressure rises rapidly, reaches to a peak pressure. It overcomes both the resistance and compliance or the stiffness. And then as the airflow decreases, there comes a phase when there is no airflow. Let's understand this. Why this plateau pressure is? Plateau pressure is the pressure to overcome the stiffness. Now the lung, if the lung has, for example, if the lung has developed an intrinsic PEEP or auto PEEP, I discussed about the PEEP in our last class or last lecture when I was talking about NI. You all understand now what the auto or intrinsic PEEP is. Now, if there is intrinsic PEEP in the alveolus, the pressure, the peak pressure is there. Now the pressure starts decreasing. And when that pressure comes equal to the PEEP pressure or intrinsic PEEP, then there will be no flow because there will be no pressure gradient. And at the absence of flow, the pressure that remains there is the plateau pressure. And this plateau pressure, we keep a goal of keeping it below 30 centimeter H2O. And it has been suggested as a surrogate marker of lung distending pressure. So if your plateau pressure is high, the lung is at the risk of developing trauma, either volume trauma or the barotrauma. So there has been a strategy to keep the plateau pressure 30. So if you are giving a tidal volume and you are applying an extrinsic PEEP, titrate the volume and peak so that your plateau pressure remains less than 30. But there is pitfalls with the plateau pressure. The plateau pressure changes not only with the lung mechanics, it also changes with the body habitus, positioning, effects of gravity, and abdominal pressure. For example, if a patient is obese their chest wall compliance will be low. When the chest wall compliance will be low, the plateau pressure will be falsely elevated. So there are the situations where plateau pressure can be falsely elevated, and you cannot use plateau pressure as a guide for the lung protection strategy. You cannot always use the plateau pressure. So there are pitfalls with the plateau pressure too. So when there is pitfalls with the tidal volume, restricted tidal volume, when there is pitfalls with the plateau pressure guide, then the question is, how are we going to protect the lung? What ventilator strategy should we adopt so that the lung cannot be injured? And the answer is the driving pressure. Now, understand this is something we all need to understand when we are going to manage the patients with diffuse lung disease, ventilating the patients with diffuse lung disease. Now, the concept came of the driving pressure. What is driving pressure? Driving pressure is pressure minus PEEP. So to know the driving pressure, we have to know two values, plateau pressure and PEEP. In the last NIV class, I discussed about the PEEP. Now I discussed about the plateau pressure. So we know the plateau pressure, we know the PEEP, and therefore we know what the driving pressure is. Let's make this understanding more clear. We have discussed the compliance. The compliance is the change in the volume by change in the pressure. Each unit change in pressure, whatever change in the volume is occurring with each unit change in pressure is the compliance. I just discussed in my first or second slide. So respiratory system compliance means change in volume. And what is the change in the volume? The quotient of tidal volume. That is the volume change that is occurring. And what is the change in the pressure? When we talk about the compliance of the alveolus, we talk about the pressure in the alveolus. And that pressure is the plateau pressure and the PEEP. And so a plateau pressure minus PEEP is the driving pressure. So the respiratory system compliance is the tidal volume divided by the driving pressure. So if you shift the equation, the driving pressure becomes tidal volume divided by respiratory system compliance. So to know the driving pressure, how it is important and how we need to implement it in the mechanical ventilation, we have to understand the respiratory system compliance. And how do we know the compliance? By looking at the pressure volume curve. Compliance in the change in the volume per unit change in the pressure. So we'll have to look how much volume change is occurring with the change in the pressure. Now the pressure volume curve is a sigmoid curve. You know why? See, if you see the curve, in the initial portion of the curve, which is red, a large amount of pressure change is required to bring small change in the volume. A large amount of pressure is required to bring a small change in the volume. So this is the initial red line that you are seeing in the sigmoid curve. And this is because to recruit the collapsed alveolar unit. And we call it lower inflection point. So any ventilation below LIP will be to recruit the lung into the ventilation. Then is the green part of the sigmoid curve. In the green part of the sigmoid curve, a smaller change in the pressure is leading to good volume change. And finally, there is a red portion in the terminal part where a large amount of pressure change is again bringing a small change in the volume. So there are 2 points where large change in the pressure is bringing small change in the volume, and we call it LIP, as an upper point is UIP, that is upper inflation point. To prevent the lung injury, we have to ventilate the patient in the steepest portion of the pressure volume loop or pressure volume loop, that is the green part. So we have to ventilate the patient in the green part of the pressure volume loop. If we are using a ventilation below LIP, if the patient is ventilating at a pressure which is causing not much change in the volume, then what's happening? The airway is the alveoli is opening and closing, and this causes atelectroma. So there is the high risk of lung injury. And if the patient is ventilating above UIP, then there is chance of over distension and there is chance of volutrauma or barotrauma. So we don't want to ventilate our patient below LIP. We don't want to ventilate our patient above UIP. Where do you want to ventilate the patient? We want to ventilate the patient in the green zone. If you ventilate the patient in the green zone, then work of breathing will be less. If you ventilate the patient in the green zone, then the lung compliance will be optimal. And this is the green zone, and this is the area where we need to ventilate the patient. And to ventilate the patient in this area, that is the driving pressure. And that driving pressure has to be low. Why? Because in this area, a smaller change in the pressure is bringing a good change in the volume. So this is the most compliant zone where we do not need much pressure. So this is what the driving pressure is, and we need to keep the driving pressure low. Where is the evidence? We are talking a lot about, chalkboard. We are talking on the chalkboard. Has there been an evidence of benefit of doing this? Yes. This is a landmark article published in 2015, and it measured the relationship between driving pressure and survival or mortality. Let's see this. This is not very complicated. We have the three different, paradigm. In the first figure on your left-hand side, you see a gray bar. A gray bar is the plateau pressure. You see a black bar, which is PEEP. And the difference between the gray bar and the PEEP is the driving pressure. So in the first curve, in the first graph, if you see that if you keep the PEEP same and then increase the plateau pressure, if you only increase the plateau pressure, keeping the PEEP same, it means driving pressure is high, because driving pressure is plateau pressure minus PEEP. So driving pressure is high. When the driving pressure is high, the mortality is high. Second, if you increase the PEEP and at the same time you are increasing the plateau pressure also, so difference between plateau pressure and PEEP, that is driving pressure, remains constant, then it has no effect on survival. Third, if you increase the PEEP, keeping the plateau pressure normal, that means you are decreasing the driving pressure, then it has got certain survival benefit. So we know that keeping driving pressure low gives the survival benefit to the patients during mechanical ventilation. Again, in the same study, on your left-hand side, if the tidal volume is adjusted to the ideal body weight, that is 4 to 8 ml per kg of ideal body weight, then it doesn't have any effect on the survival. But if you titrate the tidal volume with compliance of the lung, that is, if you drive the tidal volume as per the driving pressure, then there is definite survival benefit. So it becomes really important to adjust the tidal volume with the lung compliance. And this lung compliance, for the lung compliance, we have an idea of having driving pressure, and we know that how we need to calculate it. But the point is, what is safe driving pressure? We don't know. We actually don't know what exactly the safe driving pressure is. But through the study, the same study, we observed that if the driving pressure is above 16, then the mortality is high. So we want to keep the driving pressure below 16. A recent study has also observed the same thing, that if we keep the driving pressure below 18, then the patient has survival benefit or survival advantage. So our driving pressure target should be 16 to 18 centimeter S2O. And the driving pressure is plateau pressure minus PEEP. So we need to know what the plateau pressure is, and we need to know what the PEEP is. And by this, we will know the driving pressure. Now, understand this concept of driving pressure with the compliance. Suppose you have this, on the right-hand side, you are seeing the compliance. Left-hand side, you have all three values, plateau pressure, PEEP, and driving pressure. If we increase the PEEP, compare from the previous slide. If we increase the PEEP, correct? And by increasing the PEEP, if the driving pressure is increasing, it means if we increase the PEEP, the plateau pressure is not increasing. Only PEEP is increasing, and therefore driving pressure is getting low. So if you increase the PEEP and the driving pressure gets down, it means you are ventilating the patient below LIP. And if you are ventilating the patient below LIP, it's not the ideal ventilation. So initially, to keep the driving pressure, you will increase the PEEP. And if by increasing the PEEP, your driving pressure is getting lesser and lesser, it means you have to move further. You have to increase PEEP further so that you can move above the LIP. And this is here. If you increase the PEEP further and the plateau pressure is also increasing, but increase in the plateau pressure with increase in the PEEP remains almost equal, so the driving pressure still remains low. That is the ideal ventilator strategy for the patient. So you keep on increasing the PEEP till your driving pressure remains within the target. And this is when the patient is the steepest phase of the pressure volume curve. This is the most compliant phase of the ventilation. Third, if you increase the PEEP further, you keep on increasing the PEEP, and then you observe that the plateau pressure rise is much, much greater than the rise in the PEEP. So the driving pressure also increases. Now this becomes disadvantageous, because then the patient is ventilating above UIP, upper inflation point, and the patient is at risk of volutrauma or barotrauma. So this is how we have to adjust the PEEP and the driving pressure during mechanical ventilation. Giving an example to you, here is the screen of the ventilator. You see the patient has peak airway pressure of 25. Patient has plateau pressure of 18. So peak airway pressure minus plateau pressure is less than 10. If peak airway pressure minus plateau pressure is less than 10, then resistance is not a problem. The problem is the decreased lung compliance. And now once there is decreased lung compliance, you have set the tidal volume because you want a lung protective ventilation. You have set the tidal volume. The PEEP here is 5 centimeter H2O and the plateau pressure is 18. So plateau minus PEEP, that is 13. 18 minus 5 is 13. 13 is the driving pressure. So if the 13 is the driving pressure, this is the acceptable driving pressure. Now you start increasing the PEEP as we have learned how we have to ventilate the patient, guiding the compliance with the tidal volume. Now you will increase the PEEP. Suppose you increase the PEEP from 5 to 10. Now you have increased the PEEP from 5 to 10. See, is there increase in the plateau pressure? The plateau pressure doesn't increase. So you have increased the PEEP, plateau pressure doesn't increase. So the difference between these two now becomes 8. Driving pressure further goes down. It means your patient is ventilating again below LIP, and it can cause the lung injury. So what you will do? You will try to move the patient above LIP. So you will increase the P further, but after some time, this patient at the PEEP of 10 now going to develop after some time has this plateau pressure of 27. Now the plateau pressure has increased much, and 27 minus 10. Now the driving pressure is 17. It is above 17, above 16. Now if you'll increase the P further, the patient will ventilate above UIP, and the patient has the risk of polytrauma or barotrauma. You don't want to do that. So what will you do? If you remember the formula of driving pressure, the driving pressure is tidal volume divided by respiratory system compliance. So if you decrease the tidal volume, the driving pressure will decrease. And the driving pressure is the single most predictor of the mortality. Then in that case, what will you do? You won't increase the PEEP. To decrease the driving pressure here, you will decrease the tidal volume. And once you decrease the tidal volume, what will happen? The plateau pressure has started decreasing. And with decreasing tidal volume, the driving pressure has started decreasing. And this is what the thing which we call targeting tidal volume with the lung compliance. I hope you all understand this. So this is how we need to ventilate the patient. This is how we call the lung protective strategy of the ventilation. So first what you have to do is you set a tidal volume as per the ideal body weight. Make sure that the plateau pressure doesn't exceed 30. Then you start observing the driving pressure. For the driving pressure, you need to have the plateau pressure in the PEEP, and you start increasing the PEEP till the plateau pressure doesn't increase much more than the increase in the PEEP, and the driving pressure increases further. It goes beyond 16. When the driving pressure goes beyond 16, you cannot increase PEEP further. So what we will have to do is we'll have to decrease the tidal volume. Once you start decreasing the tidal volume, the driving pressure will decrease and the plateau pressure will too decrease. And this is called the, linking tidal volume to the lung compliance. And this is what the lung protective ventilation strategy is. It is also important at this point to understand that you should be able to know how much PEEP you are expected to give to the patient. This is a very separate topic, and we can discuss it during our discussion at the end of this session. But this is important because titrating PEEP is really important in order to decrease the patient ventilator asynchrony, in order to decrease the ineffective trigger, in order to decrease the failure of weaning from ventilation. So these are the things that we can have during our discussion. But I hope this makes us quite a sense that we have all understood, or quite a sense that how important the airway driving pressure is. So the take-home message from this entire lecture will be target the airway driving pressure, and this airway driving pressure targeted ventilation will decrease the ventilator-induced lung injury. And airway driving pressure is the predictor of mortality. You have to keep it below 16 because it has definitely got a survival benefit on the ventilator. And doing all these things does not require any additional equipment. You just have the ventilator and ventilator knob. You just have to attach and turn the knob up and down to adjust all these things, keeping the pitfalls in the mind. So thank you so much for your patience listening. I'd be very happy if you have any questions regarding this lung protective ventilations. Thank you so much.
Thank you very much for your early coming and timely completion. That's very nice.
Thank you so much.
If there is any questions, importance of permissive hypercapnia.
Yeah. There are certain situations when we try to, permit hypercapnia to sustain the, ventilatory stimulus to the patient. And this especially becomes important in a patient with head injury, where we need to ventilate the patient and allowing the hypercapnia to do its work. So we are actually, why are we allowing the hypercapnia? Because we want, in those kind of patients, where we want the PaCO2 stimulus, hypercapnic stimulus for the ventilatory sustainability. So specifically, those patients who have the brain injury around, the respiratory center. So these are the patients who will require higher than the normal PaCO2 to sustain the ventilation.
And there are many questions in the chat box, Dr. Madhukar.
Okay, sir. There is one question, the last question, I will start from the last. Sir, how this lung protection strategy differs when patient is in supine and during prone ventilation? Look, when your patient is in supine and prone, doesn't make a difference how do you titrate the lung protective ventilation. It does only make the difference in terms of gas exchange. When you prone the patient, you actually decrease the dependent area atelectasis, and those part are going into ventilation very efficiently. So when you do the proning, the only difference that it can make is your lower inflection point will come down, and you will be easily able to move into the steeper zone of the lung protection. But otherwise, your entire strategy is going to be the same. Sir, ACC to ARDS net protocol of high PEEP, low FiO2 and vice versa, which one is lung protection strategy and which to follow? You remember the lung protection strategy, we talk about the three strategies, restricting the tidal volume, restricting the plateau pressure below 30, applying higher PEEP. How much PEEP you are going to apply is something that we all should know. How will you know this? If you go on the ventilator screen and you push the tool button, then you will find pause button. If you press the inspiratory pause, if you press the expiratory pause, that will give immediately, that will measure the total PEEP, and the total PEEP is intrinsic as well as extrinsic. So if you subtract the PEEP that you have applied from the total PEEP, gives the idea of the intrinsic PEEP. So if you have the intrinsic PEEP, you know the intrinsic PEEP, then you will set your extrinsic PEEP, which is usually 75% of the total intrinsic PEEP. So this is how we apply the PEEP, and this is how we know that this much of the PEEP is the ideal. But in ARDS net, we are taking the PEEP beyond that, provided your driving pressure is low. You can go at a PEEP above than the intrinsic, provided your driving pressure is low. And this whole things we have just learned it now. And this is how we go for the lung protective strategy. Despite adequate lung protection strategy, if patient do not maintain oxygenation, what to do next? Directly shift to VV, ECMO, or increase VT above lung protective strategy from. Okay. So the question is, if the patient doesn't maintain the oxygenation, you are not going to increase the tidal volume if the patient, despite adequate ventilator protective strategy, is not maintaining oxygen. Because if you're going to increase the tidal volume, it's not going to help your oxygenation. Rather than it's going to decrease your, improve your pH or decrease your PaCO2. The point is improving the tidal volume without keeping in mind the driving pressure will put the patient at risk of lung injury. So these are the patients we should be, considered for the ECMO support. If you have given the full lung protection, you have implemented the full lung protection strategy during ventilation. Sir, I'm trying to look at the other question.
There is no question.
Okay, sir. I don't think there is more question here.
Yeah, Nana. So thank you, Dr. Madhukar, for taking this very difficult topic and nicely having the mathematics in that, all the mathematics that I could see. And I tried to understand what you are talking about, how to prevent this lung injury in the mechanical ventilation. And because that is, that when this COVID cases are rising high, again, we are remembering those bad days that how people suffered. So we should be ready. And we pulmonologists got the recognition because of the COVID. And yes, we are much more respected than before the pre-COVID era. So let us take the task that all the listeners should be the better or best pulmonologists. Thank you very much for the very great teaching. Thank you, Dr. Madhukar.
Thank you so much, sir. Thank you so much for having your
Good
blessings.
night.
Thank you.
Good night.